I see is you Alan Snyderman. So if you could just very briefly say who you are and what your interest is.
I'm Alan Snyderman. I'm what's known as a senior cardiologist, which means I'm older than everybody else. I'm honored to be a colleague of Matthias, but I remain interested in learning about how to the pathophysiology of coronary syndromes and stuff, and your technology is of great interest to me.
Thank you. Next one would be Saurabh Malhotra.
Hi, everyone. Thank you, Matthias, for inviting me for this workshop. I'm Saurabh Malhotra. I'm the Director of Cardiac Imaging at Cook County Health in Chicago. My interests, clinical and research, are in infiltrative cardiomyopathy, specifically amyloidosis and cardiac arrhythmogenesis. And I'm just very intrigued by what Matthias had discussed previously when we had met, and I'm just here to learn more about this technique and see how we can implement this at our facility.
Thank you very much, Malhotra. Francesca Freya is the next one here on my list.
Hello, everybody. I'm Francesca Freya from Pisa. I'm working in a clinical MRI cardiac center. Our interest is in the study of oxygenation sensitive sequence, and as soon as possible we want to start a project with this new technique.
Thank you. And then I have cardiac MRI, but I think that's you, Kathleen or Liz. But I don't know who's behind it now. Maybe you also want to say something. Otherwise, we'll move to the next one. Would be Carlos Guerrero from Colombia.
Yes. Hi, everybody. My name is Carlos. I'm adult congenital heart disease. I had the pleasure to working with this group at Montreal, and the interest on OS, as I have been working with the group, is in congenital heart disease, especially in dextro position patients with status post atrial switch, to see if they have coronary dysfunction, and why not later in Chagas disease. Thank you.
Thank you. Maggie Leo from Montreal.
Hi, everyone. My name is Maggie, and I've been with Dr. Friedrich's group now for the past 3.5 years at the research scanner, and just the potential that we are capable of doing with the OS sequences and other research sequences is just quite fascinating. So it is a true pleasure to work with this team. Thank you.
Thank you very much. Kathleen?
Hi, everybody. I'm Kathleen. I'm the assistant of Dr. Friedrich here in Montreal, and as well, I'm the administrative coordinator manager for CMR research here in Montreal.
Thank you. Then I have Liz Hillier as the next one here.
Hi, I'm Liz. I'm one of the Liz's. I've worked with Matthias for 7 years now, a lot. I did my PhD with him, specifically on oxygenation sensitive CMR. So it's nice to see everyone here, some returning faces, some new ones. So excited for you guys to hear about it today.
Thank you, Liz. Kate Lindsay.
Hi, everyone. I'm one of the PhD students in Matthias's group. I recently finished my master's with our group as well. And that was using OS to look at microvascular function variations in healthy individuals. And now I'm working on a patient group of metabolic syndrome patients here at the hospital. So that's my main interest in OS.
Yeah, thank you. The next one I have is here. It says Florian, but I think I see Faizi there. Is that correct?
Yeah, hi. I'm Faiza, and PhD student at McGill University under the Dr. Matthias Friedrich supervisor, and now I'm working on the synthesized T1, T2 weighted by using the OS-CMR images.
Okay, thank you very much. So my order got just somehow scrambled here, but the next one here is now Maisa.
Okay, yeah.
Hi everyone, my name is Maisa. I'm a master's student under the supervision of Dr. Friedrich, and my interest is mainly on looking at the link between anxiety and cardiovascular function using OS-CMR.
Okay, thank you. And then I have here, as I said, my order just changed again. So I have Adonis.
Hi, so I'm Adonis. I'm one of the project managers for Dr. Friedrich's team, and I've been working with him for about 3.5 years now.
Thank you. So Adonis will manage a lot of the data flow and whenever it comes to core lab activities. Yeah. Then Ludovica.
Hello, everyone. I'm Ludovica. I'm a PhD student working at the University Hospital in Lausanne in Switzerland with the group of Matthias Stuber. I'm joining today to learn more about oxygen-sensitive CMR and eventually see how I can work in this topic in the context of my PhD project.
Okay, fantastic. Thank you. And we stay fairly close. Jérôme, yearly, you were just here, but you're usually in Switzerland, right?
Hi, Matthias. Hi, everyone. Yes, indeed, I was in Canada just a few weeks ago, and I'm also from Lausanne, from Matthias Stuber's group, and basically I'm attending this symposium because we want to learn a bit more about OS and to see if this is applicable for the free running framework that we've developed here in Lausanne. So we'll see.
Yeah. Okay, thank you. Then I have Shadi here. Shadi, can you unmute yourself? Yeah.
I'm Shadi. I'm the master student of Dr. Friedrich. I'm working at Montreal, the McGill University Health Center, and my thesis project is to evaluate the coronary vascular function in heart failure patients by using OS-CMR. So I'm interested in OS, and I want to know how it works in other groups.
Thank you, Shadi. Then I have here Sonia Borodzic-Jajic.
Yes, hello everyone. I'm currently a CMR research fellow at Amsterdam UMC, and my research interests focus on ischemia detection in CMR. That's why we are very interested in OS-CMR as a new method for ischemia detection. Yeah. So I'm very happy that we can join this webinar.
Okay, I see that more people have joined than I had expected. So I hope the introduction won't eat up most of the morning here. So let's, we have to probably speed up now a little bit. So Marcos is the next one here on the list, Marcos Saldana.
Hi, I'm working with Dr. Chetrich on the amyloidosis project, also in Dr. Friedrich's lab. And yeah, I just wanted to learn more about the OS-CMR technique today.
Okay, thanks, fantastic. Glissant, something short on you?
Hi, my name is Glissant. I've been with Dr. Matthias Friedrich for the past few months. I'm a student at McGill studying neuroscience, and I've been working a lot on the data extraction and analysis part.
Then yeah, I have here Jason Thompson. Okay, apparently he's still muted. So okay, let's move on. Vasvi, so short word on yourself.
Yeah, hi everybody. I'm Vasvi Singh. I'm a multimodality imaging cardiologist, and I'm the director of the cardiac MRI program at HCA Midwest Health. I'm located in Kansas City. Thank you so much, Matthias, and the team for the invitation, and we're really excited to collaborate on the project.
Yeah, thank you. Thank you. Then Arseni.
Yes, hi. I'm a master's student with Dr. Friedrich, and I was just curious, so I joined.
Thank you. Zilke?
Yeah, hi. My name is Silke Friedrich. I'm the VP Medical Affairs of Area 19. I'm a physician with 20 years of experience in the medical device industry. And we are the company that is building and developing the software to analyze the OS images.
Thank you. Katarina?
Hi, I'm Katarina. I do my PhD with Matthias. I act as an intermediary between McGill and other sites, so I'm here to learn more as well.
Thank you. And then I have here Lina calling in from, I think that's the farthest from India and Chennai. Thanks for calling at this time of the day. Lina.
Hi.
Yeah. Hi.
Hi. I'm Lina. I'm radiologist. I'm probably the odd one from all of you. I'm hoping to have more collaborations on this OS-CMR. I'm still probably have not started the project. I'm hoping to learn more during this symposium. Thanks for inviting me.
Then I have Julia Fisch.
Hi everyone, I'm a PhD student from Amsterdam, and I did my research internship at McGill, where I also work with OS, and I'm also going to implement it in my own PhD project here in HCM patients, so I'm happy to learn even more.
And you're calling it from Amsterdam, right?
Yeah, exactly.
Okay. Then I have here Maja.
Yes, hi, my name is Maya, I'm MD, and I recently graduated from Master's in Family Medicine under supervision of Dr. Friedrich, and I think I'm the only student here that is not focused on oxygenation changes in response to breathing maneuver, but on the electrophysiological responses to breathing maneuver, including heart rate response. And in my project, we want to look at the diagnostic performance of the heart rate response to breathing maneuver for ruling out significant coronary artery disease in suspected patients. Thank you.
Thank you very much. And then I have here Simona. That's the last one, if I have not missed anybody. Simona?
Hi, everybody. I'm Simona from Fondazione Toscana Gabriele Monasterio in Italy. I'm a little bit out of topic because I'm a mechanical engineering background, but I work on biomedical field, so this is why I'm here for my interest on this technique. Thanks.
Thank you very much. And I think Javad also joined. Javad, if you could just briefly introduce yourself.
Hi, I'm Javad. I'm a radiologist, and I'm working with the CMR group of McGill since 2021, and I'm part of core lab and part of clinical radar. And just, I'm so interested to new cardiac MR techniques, especially oxygen-sensitive cardiac MR. Thank you.
Okay, thank you very much, everybody. So I will speed up with my introduction, otherwise to make up for some time. So as we can see, we have here really a fantastic group of experts from North America, Europe, India, and others from Australia just couldn't join because the time zone difference is even more painful. So I will, during the next minutes, I will just try to give a little bit a backsplash on what we're talking about. So first of all, I want to disclose, I don't show the slides, but that I'm also involved in software development with Area 19, with a company that currently produces the tool for evaluating that. I'm also a shareholder and sorry, that was too early. A shareholder of Circle Cardiovascular Imaging, where I also provide some advice and have research agreements with Siemens, Philips, and GE on various sites. Okay, so the most important problems in cardiovascular disease are coronary artery disease, microvascular dysfunction, and INOCA. And we talk a lot about microvascular dysfunction, but in fact, we have to probably acknowledge that whatever it is, coronary artery disease, or whether we call it coronary artery disease or microvascular dysfunction or INOCA, eventually we're talking about the same thing, which is an inflammatory progressive disease of the inner lining of the coronary arteries. They can come with or without stenosis, but in any case, they are likely to come with a lack of responsiveness to triggers that usually should lead to vasodilation or vasoconstriction. So a problem of the function of the coronary vessels, that's what we're basically talking about in this disease. If you translate that to the brain, then we talk about cerebrovascular disease leading to entities such as dementia or stroke. And then we have also inflammatory heart disease, especially in these times of COVID and post-COVID, where we understand that inflammation also affects what we then see as a vascular dysfunction in the brain and the heart. And so a very important underlying cause for the problems, in fact, are related to inflammation. And inflammation is something that happens in COVID, of course, but also in coronary artery disease. And inflammation is characterized by tissue edema, something that is a little bit overlooked from my point of view, because the tissue edema leads not only to myocardial stiffness and thereby to shortness of breath, but also affects the vasodilatory capacity of capillaries and therefore what we could call coronary vascular function. So microvascular dysfunction is tied to inflammation, and it leads then to a lack of the adaptability to an increased demand. So the oxygen supply cannot be provided, and that leads to chest pain and or heart failure. So this sequence of events has been studied over and over, and this is just one example where this was shown to be a significant component of heart failure with preserved ejection fraction, one of the diseases where we are still a little bit in the dark, but a lot of evidence points to the fact that there's, again, inflammation on the microvascular level, especially on the endothelium here, that then basically predicts symptoms and outcomes. And therefore, it is important that when we talk about coronary vascular function, oxygenation and such, that we keep in mind that inflammation plays a significant role here. The methods we have to assess coronary vascular function are, we have invasive and non-invasive methods, and the invasive ones are, of course, coronary flow measurements during interventions such as acetylcholine injection, which is endothelium-dependent function then that is triggered. But we have these here. We can look at stenosis, just more on the morphology side, which is, I think, probably the weakest of it all. And then we have endothelium-independent microvascular function that we can assess by the coronary flow reserve, so nuclear methods, but also some surrogate markers by CMR and even echo, at least in the LAD territory. And then we have the perfusion reserve index, and PET, probably the lead at the moment, because we have really significant data there, specifically around the not only the coronary flow reserve, but also the coronary flow capacity, a marker that has been promoted quite a lot by Lance Gold, who did a lot of the physiology work there. And then we can look at the oxygenation itself, which can be done by oxygenation sensitive MR, which is, of course, also affected by blood flow and blood volume. But this is one way to look at it. And then MR spectroscopy, where you can look at high energy phosphates. This is done, a lot of that is done in Oxford, which is unfortunately a bit more time consuming and complicated to get proper spectroscopy scans, especially with the spatial resolution that you would need for that. And then we have downstream effects of malfunction on the vascular level. You have the so-called diastolic dysfunction, which is basically just a hodgepodge for all sorts of abnormalities related to a reduced compliance or relaxation. And then you have in the long-term remodeling. So what's the role here for oxygenation-sensitive MR? So oxygenation-sensitive MR itself is based on the so-called Bold effect of deoxygenated hemoglobin. So deoxygenated hemoglobin has different magnetic properties, and it leads to an acceleration of the relaxation after a pulse in the MR. So which means it has other properties and can be used to generate signal intensities that differ from other tissues, which means in the so-called sequence that we use in MR, where we imprint that sensitivity to the Bold effect. So in Bold sensitive sequences or T2 star sensitive sequences, the signal will be lower if there is more deoxygenated hemoglobin. So if you have, for example, what we did initially more than 20 years ago, when you put a blood pressure cuff on the upper leg, track the signal intensity with such a sequence in the lower leg, inflate the cuff, you can actually watch the oxygen go down over time. So blood flow and blood volume also have an impact, but the signal intensity in the T2 star-weighted images is very strongly affected by the deoxygenation, and we have shown that many years ago in the forearm and also in the leg, that it's not just the blood flow that drops immediately, but then the oxygenation over time. So with this technique, initially the studies were focused on the brain, and that's where functional MRI was born. But then not that long thereafter, there was the first clinical interest. Garth Beach was one of the first using that. And then a group in Würzburg and in Berlin, we also had a study where we compared it to SPECT at that time. We used a technique that you would probably not use now anymore. It's with a different readout. So we had a lot of artifacts, and so the signal was basically all over the place. But what we could see is that when you give adenosine, that in segments affected by stenosis, there was actually a drop in signal intensity, in some cases even visible, whereas in others there was, if at all, an increase with adenosine, which increases the supply of oxygen-rich blood without increasing demand. So it makes sense that you would expect more an increase, and the decrease is more caused by a coronary steal phenomenon. So fast forward with better techniques, and this is work by Judy Luu, who's also now here in Montreal and will be involved in a lot of the research. The image quality could be kept much more consistent. And this is a study published already a while ago, where we could show that the change of signal intensity, which is a mark for the oxygenation, after adenosine can actually differentiate people with abnormal versus normal fractional flow reserve. And now again, fast forward, then based on observations a long time ago in Berlin, we looked at the impact of breathing. And this is let's say a little bit of a complex slide, but in fact, it's not that difficult. So we know that changes of carbon dioxide, and this is in German, I apologize, changes of carbon dioxide lead to a change of coronary blood flow, which means if you hyperventilate and get rid of your carbon dioxide, you actually reduce your blood flow by about 25% within 60 seconds of hyperventilation. And then the same happens, CO2 also has an impact when you do the opposite. If you hold your breath, the carbon dioxide will increase. So then on the curve, you move to the right side. So coming from this hyperventilation, reduced blood flow, to 30 seconds of breath hold, you see that your coronary blood flow has increased by about 100%. In animal studies, we could show that this, in controlled experimental settings, this is even significantly higher. What that means is that changing carbon dioxide, basically on the fly in vivo, by breath holding and hyperventilation, alters the vascular tone. So if you hyperventilate, you go into vasoconstriction, reduced coronary flow, and if you hold your breath, you do the opposite, to be into vasodilation. Oxygen has actually the contrary effect. The more oxygen you have in the blood, the more vasoconstriction. The less oxygen, the more vasodilation. So there's a lot of work being done in Bern by Dominic Günsch that also has affected now how anesthesiologists see that. So, but in a nutshell, it's important to understand we can increase coronary blood flow. And if you do not increase your work significantly, then you have a net increase of oxygenated blood. So here in summary, the protocol that we're using, so 1 minute of normal breathing is followed by 1 minute of hyperventilation, bringing the normal system into a vasoconstrictive state. And then the breath hold, as long as possible, then brings that from the vasoconstricted to the more vasodilated state, associated by change of these markers, CO2, blood flow volume, myocardial oxygenation, and then the myocardial T2 or T2 star as the bold signal intensity change triggers. So this is the protocol that we are using. And with protocols as such, we have shown that in healthy athletes, of course, the apnea leads to an increase of the signal, whereas hyperventilation leads to a decrease. So this was just the proof that you can show this in vivo. We have done this in healthy people, compared it with adenosine, and we could show that while in the myocardium there was not much change, and this is signal intensity analysis in the same picture, so it's not a technical aspect or not heart rate or whatever. Whereas in the myocardium you have an increase, which varies between people, but on average is stronger than what you can induce by adenosine, at least IV adenosine. And hyperventilation had this effect, this vasoconstrictor effect. We then went on to animal models where we, by inducing coronary artery stenosis, we could demonstrate that the territories that are exposed to induced stenosis indeed had a response that was significantly different from animals where we did not induce stenosis. They just had a sham operation. So an FFR relevant stenosis responds differently to hyperventilation, and during the breath hold and signal intensity analysis shows a clear difference. Then we moved on to non-ischemic disease, to the so-called microvascular dysfunction area. And this is an example. The first clinical trial on that was in patients with sleep apnea, where we could show that especially in people who had CPAP therapy, not necessarily clinically more severe, but the CPAP had a particularly bad effect, but all patients with obstructive sleep apnea had a delayed response to the post-hyperventilation breath hold. Then data from burn showing that when compared to healthy people, people with coronary artery disease had an abnormal response in the affected coronary territories as opposed to remote segments, which behave very similar to what we would expect in healthy people. So stenosed territories could not increase, but even showed on average a mild decrease of the signal intensity as a marker for the oxygenation. Then there were also people with a global severe microvascular dysfunction, or not micro, let's call it global coronary dysfunction. They had a decrease over time. So that's why, and a recent presentation by Alan Snyderman in our department triggered that and confirmed to me that we should not only stare at stenosis. Coronary dysfunction is a problem of the entire vessel, and it can be a stenosis that does that. And it's important because a stenosis may be subject to a mechanical intervention. But in fact, ischemia does not need coronary artery stenosis. So importantly, in another disease, HFpEF, so heart failure with preserved ejection fraction, where also microvascular dysfunction is considered important, delayed or an abnormally low response to these triggers was also found, and it was actually together with strain abnormalities the most frequent abnormality. And it was interestingly enough, it was related to septal wall thickness. So it supports the hypothesis that HFpEF may be caused by myocardial edema. But in any case, taking into account that CMR allows also us to look at anatomy and function, extract strain data, and look at tissue characteristics, the addition of oxygenation and the response to a vasodilatory trigger with a breathing maneuver would provide very important information. And this is some of that. Other groups have repeated and confirmed some of our data, not just Bern and Heidelberg, but also here data from Boston in hypertension, and here from a Chinese group in patients with recent acute infarct. They even found already after 10 seconds a significant difference, and were able to identify the abnormal response in the area at risk. So here are some data from Heidelberg, where the breath hold was used and compared with adenosine, but not to look at oxygenation sensitive imaging, but looking at strain. And they could show that the strain response was also highly abnormal in ischemic segments, which and had a high diagnostic accuracy. And also data, and this, by the way, this just took 64 seconds in total. And also data from Heidelberg published quite recently using now the breathing maneuvers and strain imaging. So strain imaging using so-called fast senk, so strain encoded MR imaging also had a negative predictive value of 100% and a positive predictive value of 77% with an overall diagnostic accuracy of 95% to identify patients with acute coronary syndrome. And those were all patients who came into the hospital with chest pain and a risk. So they were considered at high risk. So even there was a significant discrimination possible using breathing maneuvers together with, in this case, strain imaging. And this is data from Bern, where this was combined, where you looked at both oxygenation and strain. And by that, they could improve their area under the curve to 0.91. So with a high diagnostic accuracy, in this case, to identify hemodynamically significant coronary artery stenosis. Of note also, we looked at the preference of patients and referring physicians, and both patients and referring physicians would, when compared to other studies like CT or stress echo or stress perfusion or PET, both would have a strong preference for a breathing maneuver enhanced MR scan. So it's also, I think this is increasingly important that we also listen to patients and their preference and also the referring physicians. So these were clear data that there is also on there and there's a preference. So, and this is the last thing I want to show. This is just more a look into the future. So this is what we have seen so far. This is a patient with occluded LAD, and you see that especially during systole, as opposed to the other, in the short axis view to the other territories, there's a discoloration, which in this case means that normalized to the exoxygenation in the left ventricle and the right ventricle, as basically the scale, there is a relative strong deoxygenation during systole in the LAD territory. Here's a patient with a stenosis in the RCA. You see also that's a dynamic, it's not a static problem ischemia. No, it comes and goes during the cardiac cycle. And this one is a particularly nice case where in a combined stenosis, LAD and circumflex. And here you can see this kind of area in between where you might think, oh, what's happening here? It seems to be in the center of the abnormal area. There seems to be something normal. How can that be? And if you look at that in more detail, it looks like it would be false negative in this case. But the solution was very simple in this case, because when we looked at perfusion, we saw, first of all, even more confusing, oh, wow, this apparently normal oxygenation response actually has the worst perfusion. So you would think, so they were wrong. So oxygenation is wrong because perfusion clearly shows that the problem is more in the center. But then comes late enhancement and it clarifies that this is actually a small infarct. So in the infarct, you do not have deoxygenation. So this is not false positive, false negative, but this is correctly negative. But what you see around it, that there's peri-infarct ischemia, that was not even picked up by the perfusion and of course not by late enhancement. So this is of course just an anecdotal example, but it highlights the potential of this technique to provide significant additional information. So what we want to do is now, after my brief recap of the OS-CMR, we want to update you on recent and current research, so stuff that I have not shown yet. And then we will briefly hear about how this is done and how it's analyzed. And then we will hopefully together have a look at what interesting projects could be now then in the pipeline. So happy to take any questions, but otherwise I would then hand over to Maggie, who will show us in brief how she is scanning these people. But any questions, just speak up. Or write, if you don't feel like speaking up, can always write it in the chat. So we're always monitoring the chat. Okay, so then let's go to scanning considerations from Maggie. Go ahead.
Thank you, Dr. Friedrich. Thank you. Okay, so I'll go ahead and start. So like Dr. Friedrich just said, I will talk about some scanning considerations. Oops. I can't. Oh, okay, there we go. Check this out. Okay. So we just heard Dr. Friedrich speak about some oxygenation sensitive CMR basic principles and clinical potential. And other members will also speak about past, present, and some upcoming projects. I will direct you to the continuous OS-CMR portion of this diagram. And this presentation will focus on the scanning considerations, demonstrate some key practice areas, and some results will be shown by my colleagues and discussed a little bit later. Okay, so before we begin, we always make sure that we have the following items on hand and ready for use. And the first being very important, the video with the breathing maneuver demonstration. Next in line is the video displaying the pre-recorded voice commands connected to an audio source are used so it is easier for the patients to hear and therefore improves compliance, consistency, and reproducibility. Heart rate sensor, respiratory monitor, and timers are also used to document the following important points, being the baseline heart rate, the maximum heart rate during hyperventilation, and the breath hold duration. The participants or patients' first introduction to the breathing maneuver is done outside of the scanner room and is done in conjunction also when we're doing our safety questionnaires before we enter into the magnet room. This is very important since it clearly shows the patients how not to and how to perform the breathing maneuvers. In this video, our model initially and purposely does it wrong because he will breathe with his chest. And afterwards, he is corrected, and notice the difference, how he transitions into abdominal breathing as opposed to chest breathing.
Breathe more deeply.
So our model is quite experienced, and so he is breathing in and out through his nose and mouth respectively. But for the patients that are doing it for the first time, we strongly suggest that they breathe in and out through their mouth, which makes it easier for them to stay in sync with the metronome. So once the participant is inside the scanner room, we quickly take, when we're doing the setup, we take about 30 seconds or so just to practice with them and just to make sure that they have grasped the concept and technique. At this point, it is crucial to reiterate that abdominal breathing is what they need to be doing as opposed to chest breathing. And we always use a bellow or a respiratory belt around their abdomen so that we can follow their breathing and make sure that they're always breathing with their abdomens. So I will direct your attention now to the right side of the screen where we see how he transitions from just a regular, relaxed, normal breathing and how he starts his hyperventilation. Note the respiratory rate here at 24 and how his baseline heart rate is 68. Oops, sorry. No, let me go back. Sorry. He takes about 2 or 3 breaths before he falls into tempo with the metronome. So after 5-10 seconds of starting, already his respiratory has reached the desired rate of 30. And his heart rate, his initial heart rate was at 68, and already he's up at 75. And this is again within the first 5 or 10 seconds of the hyperventilation. Just as an added note, that the heart rate response during hyperventilation will increase by about 20 beats per minute for healthy volunteers. In this slide, I would like to show the parameters, how we came about to using the OS parameters. So we took a basic BSSFP sequence and we modified 4 parameters in particular. One being the flip angle and how we diminished from 80 degrees down to 35 degrees. The slice thickness from the BSSFP sequence was increased from 8 millimeters to 10 millimeters. The echo time was increased from 1.2 to 1.7. And consequently, the TR, the repetition time, went up from 2.9 to 3.5 milliseconds. Now, these parameters are modified, and these modified values represent a balance between a T2 star weighted sequence, significant signal to noise ratio, and image quality. So how do we plan this sequence? We begin with an OS scout, which is acquired using a short 10-second breath hold, approximately 10 seconds. We always plan in end systole. So the first slice that we use is a mid-basal slice that is strategically placed to avoid both the mitral and tricuspid valves and avoid also the flow artifacts coming from these valves. The second slice is a mid-ventricular slice. And then we go through the whole cardiac cycles just to make sure that, and we want to verify the positioning, that both slices are positioned properly. Now, these baseline images serves as a dual purpose. The first being that we need to verify that both these short axis slices have good image quality, are void of artifacts, and are well positioned. The most common artifacts seen with this sequence can be in the infralateral aspect of the myocardium due to its close proximity here to the stomach. If this is the case, you see an artifact in this region, just duplicate and set up your sequence and perhaps modify either your shim or your centerings just to avoid the artifact from this region. And also to note here, the shim that we use is focused around the 2 slices as opposed to a full shim that covers the whole heart. The second purpose of this sequence is that we will see later is it is used in an comparison analysis with the post-hyperventilation breath hold sequence. Another parameter that is very important to consider is the total number of phases, because this value here will affect the total acquisition time, which is here, which in turn is affected by the heart rate. So this example, I have not updated my slide, but this example is when we were using the 4-minute continuous acquisition. So we used total number of phases of between 25 and 27 just to have ample time, acquisition time, so which we always aimed for over 5 minutes. Now with the 3-minute continuous acquisition sequence, the total number of phases will be more in the 20 value. In this next slide, the purpose of this slide is to show the images during free breathing and hyperventilation. The images look very blurred, and which is expected. So there's nothing wrong with the sequence. There's nothing wrong with your machine. The patients are breathing right through the sequence, so the images are expected to look blurry. Contrary to the free breathing and hyperventilation, your breath hold sequence needs to be very sharp because the patient is, after all, holding his breath. If the images are not sharp, then that means the patient started breathing through this sequence, so you'll need to stop the continuous acquisition and you'll need to repeat it. One important point is that because the patient has just finished hyperventilating, you will need to wait about 3 minutes and give the patient time to his heart rate to reduce back to the resting heart rate. And then it is very important to repeat both the OS Scout and the OS continuous acquisition. Now, Now that we've acquired both the OS-Scout and continuous acquisition sequence, what do we do with these sequences? So the first one of the comparison analysis is done with the OS-Scout and the 0 time point right here, the 0-second time point. And this will look at the effects of hyperventilation, therefore the vasoconstriction on signal intensity. Then another analysis that is done is using the the 0 time point post hyperventilation and the 30-second time point. And we calculate a % difference of the signal intensity across the breath hold, which is the vasodilation. So, and this is what we call the myocardial oxygenation reserve. So in conclusion, the oxygenation sensitive CMR is a fairly simple technique that can easily be implemented and adapted by various vendors. And again, the demonstration and practices done outside and inside the scanner are crucial for the proper and successful execution of the sequence. And the clinical potentials are very promising, which the following speakers will indicate. Thank you for listening, and a special shout out to this phenomenal group that truly inspires me, and a special thank you to Drs. Friedrich, Hillier, and Luu, and soon to be Dr. Eyre for their invaluable assistance with this project. Thank you.
Thank you very much, Maggie. So for those of you who may have lost track with and I apologize for not having had my video on, I just realized now. For those of you who lost track of the details, as we said before, the talks are recorded and you can download them. So then next thing I would then ask, unless there are any burning questions, I hope that Mitchel is already on the call because he had another, okay, great. So I would ask you then now to give us a brief insight on how this is analyzed. And Mitchel is the CEO of Area 19, the company based here in Montreal that looks into providing an automated tool for the analysis of these images.
Right on. Can I just do a little slide check here? Everybody sees this correctly?
Yeah. Yes.
Okay.
Yes. And maybe, Mitchel, you also briefly introduce yourself.
Hi, certainly.
Yeah.
So like Matthias said, I'm CEO of Area 19 Medical. We're a fairly new company, actually a spin out of Circle Cardiovascular Imaging. Our primary research and eventual commercial access is really related and targeted on OS-CMR. So we've taken over all of the development and overview of the research and development related to OS-CMR. So that being said, I'm very delighted to update you all on our continued development of the tool. It's a post-processing tool, and do keep in mind that it's still very much a research module, but I think it's a very capable tool today, and we are continuously improving it. So in the context that OS-CMR is still somewhat of a fairly new paradigm with still a lot of things to discover, which is quite exciting. But we wanted to ensure that the post-processing tool would be versatile and agile to allow the users freedom to test different hypotheses quickly and unconstrained. So first and foremost, we need to support different breathing states of varying lengths. We needed automatic post-processing in the form of automated contouring on all slices and all phases, and following that, automatic biomarker extraction. And of course, all of this has to be backed up with manual controls in case of failure of the various AI systems that we use. But also to allow flexibility during this very much intense research time. So the primary breathing maneuver paradigm that we designed the module around is the 4-minute acquisition, but like I said, this can be modified. But this is the one we started with. It includes the free breathing, 2-minute free breathing, 1 minute of hyperventilation, and then breath hold. And this can be preceded by an optional 15-second baseline breath hold. Some centers do this, and sometimes we do this too at McGill. But as I mentioned before, and I'll repeat, the module can accommodate variability in the durations of these breathing states, and the states themselves can be moved around or changed. So for example, you can skip the free breathing or replace it with something else, and the module will adapt to that. So this is what it looks like. And as you can see, the module is fully embedded within Circle's CBI 42 platform. This is kind of cool because it allows us to use all of the other modules to perform your standard comprehensive analysis of your patients, and you can easily compare between the different types of acquisitions. For example, quantitative perfusion, T1, T2 mapping, etc., or strain. Now, the operation of the module is quite simple. You just need to find your continuous acquisition series on the right. You double click on it, and there's a pop-up here where you're prompted to enter the start and end phases of the different breathing states. We are working on automating this cropping step, but for now, it just takes a few seconds to fill out. And once you've entered the timing information, the breathing states are cropped temporarily and arranged in the appropriate columns, and the post-processing is triggered automatically, and we get these AI contour data sets at all slices and phases. And all of the biomarkers have now been computed also in the background. And to visualize these, you go in the result panel. This is where you can toggle between the different biomarkers that we compute. There are different representations. There's a high resolution pixel-wise maps that are dynamic. We also show graph-based signal intensity and classic polar AHA sector representation. Now, on the topic of biomarkers, we've come up with a fairly large list of quote-unquote naive biomarkers, and we're still, it's still somewhat of an open question as to which ones are diagnostically performant. So at this point, I want to introduce everybody here to our cardiome data mining system. This is our proprietary end-to-end biomarker discovery platform. It's closely coupled with the analysis platform in CBI 42. It can work on either a standalone workstation or through a multi-center federated deployment. So what this does is it can ingest heterogeneous classes of biomarkers, such as, of course, the imaging biomarkers, but also you can throw in your patient's blood serum reports, patient demographics, and environmental factors. It can even take in genomics, really you name it, and it can use it. And it then does data mining and reports on the biomarker saliency, which is another word for biomarker importance, and biomarker polarity, which is really cool because this indicates how a biomarker pushes a patient towards a disease state or a healthy control state. And once all that is discovered, all of those important biomarkers are discovered for discriminating between a pathological class and a healthy class, I can train and deploy a classifier or prognosticator to be used either retrospectively or prospectively. And this is just done in a few clicks, super easy to use. Now, applied to OS-CMR, all of the quote-unquote naive biomarkers computed in CBI 42 are arranged in a big feature matrix. And given the pathological and control labels of each patient or volunteer, it'll tell you which biomarkers are salient or important, how important they are relative to one another, and show you how the value of the biomarker pushes a subject into a likely disease state or control state. This is the biomarker polarity output. So, and as an example, on the small cohort of positive CAD and healthy controls, we wanted to see which of the OS biomarkers led to the classification of patients with CAD. And in this case, our pseudo-oxygen saturation biomarkers were found to be very salient. There are two of them at end diastolic phase and one at the diastolic phase. And now for the polarity analysis, the plot here you see on the bottom shows that the higher the pseudo-oxygen saturation is at either end systole or end diastole, the more likely the patient will be pushed to a healthy state. Whereas the lower the saturation, the more likely the patient will be classified into a disease state. So this can give you kind of a relational contribution of each of the salient biomarkers with respect to pathological presence. Now, this is a new tool that we've developed, and so far it's been very useful in phenotyping a bunch of disease states. It's really a fascinating experiment every time we run this, and we'd certainly welcome you all in multi-centric collaboration to continue exploring the biomarker landscape of OS-CMR. Thank you very much.
Thank you, and also for basically the outlook of how machine learning tools and advanced mathematics can then help not only us to understand the physiology, but also to extract all this information that is in this very rich data set that can be acquired using oxygenation sensitive MR throughout the cardiac cycle. So now we have talked about the background, how it's done, and the tools for the analysis. Now let's have a look at using all this, what so far, and especially the recent studies, have been shown us. And as I ask Liz Hillier, PhD here on that topic, and is now on her way to becoming a doctor, and is one of the most experienced people in that field. So I would ask her to talk about the previous research. And we're a little bit behind in time, so all the remaining speakers just try to go on a 1.25 speed if possible. Thank you.
Thanks, Matthias. I speak fast in general, so hopefully this is okay. Slide check. Can everyone see slides? Good.
Yeah, all good.
Okay. Thanks. So yeah, just briefly, I'm going to present some of the more recent research we're doing, including some of the kind of preliminary findings that we're going to present at SCMR. So you guys are getting kind of a teaser look at what's up and coming. So this is one of the things we published last year. Actually, it was a review article on the potential of BMOR, so the breathing-induced myocardial oxygenation reserve, to detect microvascular function in heart failure patients. And this is just a figure from that. Also, earlier this year, we published a manuscript, which was an established protocol for the acquisition of OS-CMR images in order to obtain the BMOR biomarker. And this was kind of in a collection around the non-invasive assessment for coronary microvascular dysfunction. So we were asked to write this paper, which really highlights, the potential that the field actually sees in OS-CMR. So that was exciting for us, and is now available online. So some current results. This paper is in revision. This is on the potential of BMOR in heart failure and the relationship with cognitive function. And so what we actually found in this study, so this is heart failure with both reduced and preserved ejection fraction. We found that microvascular dysfunction kind of BMOR in heart failure patients was associated with impaired cognitive status and impaired cerebral oxygenation reserve. So that was a global oxygenation status in the brain. Also, it was associated with reduced cardiac output and impaired myocardial oxygenation reserve. So all of those were correlated to each other, which was a huge finding and very exciting in terms of looking at two tissue beds basically in patients with heart failure, and that there's effects in both of those in terms of microvascular dysfunction. And on the right there's just a figure showing the correlation between myocardial oxygenation reserve and the cognitive impairment in two patients. This is a research letter that we published in Circulation last year, where we were able to show that there was heterogeneous microvascular dysfunction in patients with INOCA. So when we looked globally at the global BMOR between a healthy cohort and patients with INOCA, so ischemia with no obstructive coronary artery stenosis, there was no difference globally. But when we went at a more granular level, we were able to show that there was patchy oxygenation deficits in the myocardium of INOCA patients, which was really a new and novel finding. And what really kickstarted our new biomarker search that Mitchell just talked about with these kind of novel biomarkers that we found. One of our students, Julia, who was introduced to you guys at the beginning, she looked this summer at looking at those markers of regional heterogeneity and comparing them to the different domains of the Seattle Angina Questionnaire domains. And what we were able to see is the regional heterogeneity BMOR biomarkers were significantly correlated with 5 out of the 6 SAQ domains. And the only one it wasn't correlated with was treatment satisfaction. And so we're really kind of taking a deep dive into that data right now, actually writing the manuscript. But I think treatment satisfaction can be quite subjective as well, and is not so much based on underlying physiology. So that could be a possible explanation there, but correlated with 5 of those 6. Not only is, OS and BMOR biomarkers really showing us some exciting underlying pathophysiology, and we're coming up with new biomarkers all the time, but we are actually seeing that this is quite a reproducible methodology. And so in this study, we just repeated the breathing maneuvers that were performed well in the same patient in the same scanning session. So like Maggie mentioned, we waited that 3 minutes and we just ran the breathing maneuvers again and compared the results of that. And there was a pretty good correlation there, showing some good reproducibility in the methodology. So as Mitchell alluded to, we're really moving beyond the basic, if you will, BMOR analysis and looking at novel biomarkers and different ways to look at this data. I think that we're only scratching the surface of the potential of oxygenation sensitive CMR and the data that it's able to give us. And so we're trying to look a little bit deeper into that. Katie Fisher and Dominic Gunch in Switzerland, as Matthias has alluded to, have looked at different things, including strain. We've also looked at heart rate response to the breathing maneuvers. That's what Maya is also looking at further. And if we combine these, possibly, can we improve the outcome prediction or the classification of what we're able to look at? This data is what Mitchell had just talked about, and we presented this last year at the SCMR using cardiome to detect whether or not patients who went into the scanner with positive clinical stress tests and symptoms of ischemia, if we were able to kind of accurately predict whether or not they had obstructive coronary artery stenosis or INOCA. And this is the cardiome output. This was very naive data. We didn't do anything with this data. Basically, this was kind of our first foray into this. And there was a 73% classification accuracy, which doesn't seem that high. But when you think about, we didn't touch this data, this was all very naive. We didn't come up with any robust clinical biomarkers out of it. This is just kind of what it spit out. Not only that, when you look at some of the biomarkers and how they were able to so significantly predict or kind of delineate between significant coronary artery stenosis or INOCA, it was really quite striking. And this was really promising for us and kind of led us to believe that we were on the right path here. I'm going to talk about some preliminary results of our BMOR pilot study, and the international trial I'll talk about at the end is the multi-center one that we're running right now. So in this pilot study, we had 26 healthy volunteers, 30 patients, 20 of whom had obstructive coronary artery disease as defined by greater than 80% stenosis on QCA, and 10 with no obstructive coronary artery stenosis, so INOCA. With our novel biomarker extraction, we ended up having 3,336 data points per subject, which became overwhelming, but I'm just going to talk about some high-level results right now. When we use principal component analysis methodology to try and narrow down some of these biomarkers, but also just see, could we predict between healthy people and all patients, so whether or not that was obstructive or INOCA, we got a 96% classification accuracy, again, to delineate between healthy and patients overall. And then when we look at the B more global marker to be able to detect myocardium that's affected by obstructive coronary artery stenosis. When we look globally, so we have two short axis slices, and that is a question in the chat, so we can talk about this later. The global historical BMOR biomarker has an area under the curve of 0.82. And when we normalize to the left and right ventricular blood pool, which is a new way we're looking at it, it's 0.85. Interestingly, when we look at our most basal slice, the area under the curve is at 0.84 and 0.9 when we normalize to the LV and RV blood pool. And that's just one global biomarker, and that's pretty exciting for us. And that's still differentiating between healthy and all patients again. Possible takeaways from this: pathology may be more present in basal slices in obstructive coronary artery disease. And not only that, but the second slices of OS-CMR acquisition may have been too apical. This is the first trial that we really ran at our site. And we've really seen since then that we want you guys to acquire kind of two mid slices, and we can talk about that in the discussion as well. Moving on from a global kind of perspective to a more granular, we looked at the ability of BMOR to detect myocardial segments affected by obstructive coronary artery stenosis from unaffected segments. So can we actually say, you know, in an LAD coronary territory, can we predict whether or not it's affected or unaffected? And preliminarily, we have an 81% classification accuracy in this pilot study. When we look at some international trial results, and we're going to present this in the late breaking session at SCMR in January, a few more patients and healthy volunteers, so 62 healthy volunteers and 48 patients in this preliminary analysis. These findings are totally in line with what I just mentioned in terms of from our pilot trial. So we did find again that there was a significant global difference between the global BMOR normalized to the blood pools, and we actually have an increased diagnostic accuracy, so 89% in the ability to detect coronary territories exposed to significant stenosis or not. So this is kind of hot off the press, kind of really ongoing analysis that we're looking at that I'm pretty excited about.
Thank you very much, Liz, for a very nice, direct, clear overview of what's currently out there. Any questions related to that? I mean, there's a lot of data that have been thrown at everybody now. Any remarks or questions? No. Then I think the next one is Judy. And Judy Luu is, unfortunately, is stuck in a meeting that we didn't coordinate with this one very well with other external partners. So I will jump in and will just show very briefly what we are currently looking at here. And so this is just very in short what we are currently interested in, especially in a collaboration that was what Judy is leading, a collaboration with some centers, specifically Cedars-Sinai and also Christ Hospital in Cincinnati. So this is one of the studies, the clinical utility, where is assessed then in several patient groups with, let's say, more complicated ischemia settings. And these are specifically female-specific risk enhancers, so women with earlier menopause and those with hypertension during pregnancy. And then also mainly a disease of female patients postmenopausal, the so-called INOCA, ischemia with no obstructive coronary arteries, that is then validated against coronary function testing, specifically acetylcholine injections. And this is done together with the Christ Hospital and with Cedars-Sinai, and also with under participation of the University of Florida. Then we have, as Maja already alluded to, we are also interested in the impact of the breathing maneuver on other physiologic markers, specifically heart rate and heart rate variability. And this is a study that has been already started before with the aspect of oxygenation sensitive MR with Liz and the team in Calgary. And this is now being continued. And this is also actually a very interesting marker, the change of heart rate. And we published on that some time ago in Nature Scientific Reports, a retrospective study, but we have now data from a prospective study that confirms that the heart rate change also has an additional discriminatory value. And of course, the tool would then could integrate that. So we're also looking at the heart-brain axis, and that's Maisa's project in patients with anxiety disorder. The idea is that their breathing pattern is different, and therefore the response to controlled breathing maneuvers also may be different, explaining maybe some of the evidence that we have that patients with such diseases like depression or anxiety indeed have a higher incidence of cardiovascular issues and even prognosis. So we have a website, and I now have to just change what I can share here. Have to show you that here. So this is just going down our website, what we are doing currently here, and I'll keep that short. So it was already mentioned, and you can look at our website to see that. So that's public side here. So we have the team is called the AIR team because it's about the oxygenation with the breathing maneuvers. And we have a project in healthy people that includes data from the so-called Quadra Cardiovascular Signature Program, which is a 4,000 participant cohort. We have currently already scanned about 1,000 people, and about 1/3 of those are healthy, 1/3 has risk factors, and 1/3 has overt disease. And looking at how in healthy people age and other biometric and contextual factors affect the BMOR response. The MetaMOR does that with a focus on risk factors. And then we have a study where we compared the results between different scanners and field strengths, and this is will be submitted for publication soon to see whether interscanner variability causes a big problem. And then we have a study where we look at the capacity of OS-CMR in differentiating ischemic from non-ischemic cardiomyopathies just based on their pattern of dynamic oxygenation over the cardiac cycle. And then I already mentioned BGLADS. That's a study on breathing-induced changes of oxygenation in the myocardium and in the cerebrovascular tissue or cerebral tissue in patients with anxiety and how they respond to therapy. And then we have the, as mentioned before, Maja's study on changes of heart rate and the so-called ScreenMOR. And then last not least, we're looking at the changes of oxygenation sensitive MR during hand grip exercise. And we have some preliminary data from Heidelberg, actually, that this may work also very well. So this is just a brief run through what we are currently interested in. Now I would ask around basically just some spontaneous, you can type that in the chat, areas of interest where you would say, oh no, don't do that because we are already on that, or where you say, we think we should be doing this and can you help us recruit? So the idea is, and we had something similar on quantitative perfusion, to have let's say non-binding, but a trustful relationship among a certain expert consortium that then looks at a new technique, in this case, the VMOR and associated biomarkers, using so to look at that from different angles in different populations. And we have, just to mention a few, we have, for example, PISA is interested in comparing this with CT coronary angiogram. And Sorab, you are interested in applying this clinically in patients with suspected coronary artery disease. Then already mentioned, we have Christchurch and Cedars-Sinai. They are interested in validating that against intracoronary injections of acetylcholine. So specifically looking at coronary vascular function on an endothelial level. And then we have, I see that Adrian Ruiz Lopez from Barcelona just or joined here. He is interested in using that in patients with hypertrophic cardiomyopathy to see whether what we're seeing there is related to coronary vascular dysfunction. Then I also see Marco Goethe has joined. Hi, Marco. He works together with Julia Fisch. She's also on the call, also in patients and validating that against other methods. So from a feeling I have is this is already fantastic that we have different interests and looking at how much this methodology could provide in our understanding and also diagnostic workup. But just to make it very clear, my last intent is to restrain anybody or to tell anybody what to do. I just want to make sure that we can inform each other and we can keep each other posted, help each other. And I'm grateful to Area 19 that there will be also support on their end to support the central analysis. And once the central tool is sufficiently well validated so that we do not need a manual, but a more automated analysis, then this analysis may be as short as 1 or 2 minutes and will be mainly without a lot of user interaction. And that would be the time then when centers then everywhere could basically have their own core lab based on that. And we have also support from Area 19 to get that going without too much financial or other efforts. And so that then these centers then can be hubs for others then and teach this. But I'm already talking way too much. Are there any specific questions or any ideas on what we should be doing or should not be doing? And last thing I want to say here now is we want to invite all of you, plus some others, because this was just let's say so this is the group that is considered the core expert group. But we will then invite a few others at the OS-CMR 2023 to a specific workshop, an expert group workshop, and also with the goal that mid and long term we will have an expert group at the OS-CMR, just as we have the mapping expert group, which then also will inform guidelines and such where this could be used, and then also with more detailed instructions on how. So any spontaneous comments or questions? If not, then I'll just kick it off by asking some of you. So Lina, thank you very much for joining, but it must be very late where you are. So you have a busy center in Chennai in India. And where would you see your interest and role, and in short, how one could support that?
Hi, yeah, sorry for joining back. It just got disconnected. Yeah, so our center is quite busy, and especially as you know, the Asian crowd, the ischemic heart disease is also a high burden. So of course, if this OS-CMR, if we can incorporate, of course, even into our routine practice, and when the clinicians also get to know how it can help them to, channel more patients without making them undergo intervention. I think in the long run, it's going to be a huge benefit, both from this reducing the scanner time, the cost, the overall expenditure. All those can come down, and which in the Indian situation will be a huge benefit, because most of our patients, 95 patients, they pay from their pocket. It's not like the companies or the insurance, no government insurance for most of the people. So for them, anywhere, if we can bring down the time they are in the hospital, where they can bring down the overall expenditure. So that is where I am seeing this in the long run. That is what I am hoping this can.
Yeah. So so definitely, and we spoke before, so there will be a lot of support for yourself to apply this and to demonstrate also the cost efficiency of such an approach, because it's a short scan. It doesn't require contrast agents or a pharmacological stress agent, so it doesn't need no needle. Not even a doctor necessarily has to be on site. And we can extract from this short scan strain and oxygenation, so markers for LV function and coronary vascular function. So that will be very interesting. Now I see that Vasvi, you have posted a comment that on top of the clinical application, we of course have to do the homework of looking how does it compare to current standards and basically ground truth. And that's why your interest in comparing this with PET microbial blood flow is extremely important. I don't know whether you briefly want to expand on that.
Yeah, sure. And then we spoke about our center is a little bit unique because we do have a consistent number of patients who undergo cardiac MRI. They also undergo PET stress test. And therefore, this will be a consistent population in which we can compare flow reserves and then, oxygen sensitive biomarkers in this subset of population. And then we also, aside for we do offer CT-FFR on all coronary CTs that are performed at our 4 hospitals, but also we do coronary plaque analysis by inflammation, peri-attenuation index, and then so 3 companies that we're working with for coronary plaque analysis. So if that was something that we were interested in, we could use a subset of these patients for that analysis also down the line. So I thought then that would give us a wholesome multimodality correlation and establishing, baseline values and correlative markers.
Yeah, I think that's fantastic because, and I hope Alan would agree with that, because coronary artery disease, I think, is not really just the stenosis, and it's not something happening at some specific space in the periphery or here or there, but coronary artery disease is a disease of the entire vessel. So I think plaque burden may be a particularly important and interesting marker to look at. And I would not be surprised at all if we would find out that plaque burden itself comes with vascular dysfunction, with or without stenosis. So I think this will be very interesting data. Yeah, thank you so much, Vasvi, and just let me know how I can support that. And it would be great if you could also join and talk about some of that at the meeting at the CMR. I don't know whether you want to attend, but I'm just encouraging you to. Saurabh, you have a special population amyloid. This is, I think, also fantastic because amyloid comes with huge problems of adjusting perfusion to the demand, and they have all terrible global perfusion parameters, but we do not really understand that well. So do you want to briefly expand on what you are specifically interested in?
Yeah, Matthias, thank you. So, we are an amyloid central in Chicago. We have a very high prevalence of cardiac amyloidosis here and a fairly robust program that we've been able to build over the last 4 years. We serially image our amyloid patients prior to and on therapy now, and we've had good success with that. both with MRI, echo, PYP. So, the whole gamut of information that we have. A lot of times, and it's not uncommon, these patients present with biomarker elevation like troponins, and it's thought to be from microvessel dysfunction, but has never been proven to be that from that. A lot of these patients are misconstrued to have coronary artery disease. Some of them actually do have coronary artery disease. It's a disease of the aging population. So there's concomitant epicardial disease, and along with microvessel dysfunction associated with the infiltration with amyloid. And I think very often it's difficult to tease out what's going on at that particular moment in these patients, and if assessment of vasomotor function in these patients has any implications with a progression of their cardiomyopathy or outcomes in the future. I think that's going to add a lot of value for us. Along with, I know your software is able to do strain analysis at the same time, and which we do on all our patients on echo. So that, I think, it opens up a lot of avenues for correlative imaging and adding a new, let's say, imaging-based marker to assess, myocardial function.
No, great, fantastic. And then I see a comment from Carlos. Carlos introduced himself. He's a cardiologist at the I think it's Centro Cardio Infantil in Bogota, in Colombia. And he's interested in congenital disease. And I think that's, of course, for when it's about oxygenation, this is also a very interesting population. So Carlos, do you briefly want to say what you are interested in?
Thank you, Dr. Friedrich. So yes, we are at Fundación Cardio Infantil. We do 2,500 CMRs a year. With them, 50% are congenital. And our main idea is to see if a patient that had transposed coronary vessels at early age might develop early coronary disease or early coronary dysfunction, especially in the patient with DTGA status post arterial switch, because we don't know what is the status of coronary disease in these patients now that they have been transposed the coronary at very early age. And there are some signs of early coronary dysfunction. And then, of course, there is a thinking that they might develop early cognitive impairment because of the early disease that they have, the profound desaturation that they have at birth. So also we want to try to look at this, if this means some markers of early microvascular dysfunction, and why not early cognitive impairment.
Okay, no, thank you very much. And I want to state here that the reason, I think the main reason why I like it a lot that we basically are open about talking about the research is that if we have a site that is particularly interested in one, let's say in, for example, amyloidosis, then I hope this group can foster collaborations and help with things like ethics applications. So that, for example, for a study that is led by SORAB on amyloidosis, that then there could be patients recruited at McGill. We have also an interest in amyloidosis, and in Heidelberg or other centers, so that the patient numbers can be increased and can be used as a part of a multi-center effort, which always helps with the quality of the publications and also allows us to identify possible challenges regarding whatever details of how the technology is applied and such. So that's, I just wanted to mention that this will be hopefully a major function of this group to also help each other with patients and with multi-center activities. And as I said, Area 19 for now has agreed to support a central blind evaluation. So there is not a lot of work associated with evaluating and analyzing the images that should make it much easier than for centers to start with that. Of course, if centers are particularly interested in using the prototype themselves, this would be a separate set of projects once it's validated. So any others who would like to chime in? Sonia, Ludovica, Simona, Julia, Marco.
If I can, I
Yeah.
would like to ask a question. What do you think is would it be an added value if we, for example, introduce a 12-lead ECG into like patients undergoing breathing maneuver, especially for in population of patients with suspected coronary artery disease?
Yes, so I don't know whether Maya can comment here, but but that is definitely a great idea. I would just recommend you to speak with the people here at McGill, because there's a project that has already started, so that they can update you on what has already been found. Indeed, we have a study here looking at the impact of the breathing maneuvers on ECG markers analyzed by machine learning. And there are indeed some signals, and this is a fantastic idea. So it points to let's say, a branch of the whole thing, because if you do these breathing maneuvers, not in a scanner, but just like that, there is a change of heart rate, but there's also, of course, a change of how the ECG is then displayed. And this could be an outpatient application as a gatekeeper for imaging. So you could say, okay, this is what we typically see in ischemia patients. And then setting certain thresholds, you could generate a method with a pretty high negative predictive value. So you could say, okay, this patient does this scan in quotation marks, so just the breathing maneuver with the ECG, and this patient has these markers, so the patient doesn't need to go to any imaging studies, because the negative predictive value method is good enough to say, okay, here we can, this patient does not have coronary artery disease. So I think that's a fantastic idea. So if you're interested in that, and it's always good to have at least have more than one center interested in something. And I'm sure when you speak with I don't want to speak for them now, but Maya is working with Abhinav Sharma. He was in Stanford, and he's now here in a study looking at ECG changes during the breathing maneuvers. So they would update you so that you can coordinate that better. But there's so much to do that it would be good, and it will help you to understand what has already been done there.
Thank you.
Yes, may I ask you?
Marco?
These EKG-related study, is this, you mentioned that it is outside the magnet, right? So the EKG is obtained outside.
Yes.
So we talk about obtaining the EKG during the imaging itself. So an MRI compatible imaging.
Oh, that's also very interesting. Yeah, and you see, just these two projects alone, they would open up a whole area of questions and interesting projects.
The introduction of a diagnostic 12-lead EKG in the MRI environment is new, but is probably of added value for the assessment of patients.
Fantastic, and then adding the breathing maneuvers. So if you can then see a signal in both the ECG and the image, I mean, this helps correlate things. Yeah.
So we definitely should continue.
That's fantastic. Yeah.
Okay, great.
So any other, we're already 7 minutes over time. I apologize, but I have see also that Vasvi responded that they also have a cardiac amyloidosis program. So if we can basically facilitate the communication here between Saurabh and Vasvi. Any other comments before we close? Slowly have to go to the landing strip here. Jerome, you looked like you wanted to say something, or did you want to?
No, I have a question. I mean, it's very technical, but it's because, of course, I'm interested in maybe implementing it in the free running framework. But when I look at the 1.5 Tesla protocol that Maggie presented on slide 6, I think, during her presentation, she wrote that the TR and the TE were like in the order of 39 milliseconds or 30 something milliseconds. Is that a typo, or is it?
Yeah, so I think it's a typo. The problem with TR is that different vendors use different, let's say they define TR a bit differently.
Okay,
but
so
in general, I think 39 was, I think it should be 3.9. So it's, yeah.
So it's the GETR.
Yes. So it's basically the TR should be twice the echo. That's where we typically found the best bold sensitivity. Yeah. So this is, but we can discuss the details. Is I think a very important point. I just also have to say that on the sequence development side, that's maybe interesting for you, Jerome, there is still room for improvement. So we have a sequence that works well, but the fact that it was so far not significantly altered tells me that there's probably potential to improve either bold sensitivity further or quality or both. So I think there is still, I mean, we have to say we have now, because we have so much data, a lot of what we're doing right now with normal values, etc., will still be good. But if we can improve on that, that would of course be nice. So the last thing is, what are the next steps now? So what I would suggest is that we form, let's say, a group that has a kind of a communication platform, and I will find out how best we could do that. That could be on Slack or whatever. So first we'll have to get started with emails, but email is just a horrible tool to communicate among many people. So that we have a kind of a go-to person, and then see how we can help each other. So Vasvi, your question regarding research contract, so we have templates for that, and certainly we can also help with our expertise with ethics applications. So we can send out approved ethics applications that typically help getting ethics approval elsewhere, although luckily, because there is neither radiation nor injections involved, it typically is not that difficult. But we will try our best to facilitate that. Then the communication between teams, that of course should also be encouraged, but I hope that we can then use the platform to also allow for bilateral communications, for example, between Marco and Sonia and Vasvi and Saurabh and myself and Adri and whatever. So that we also facilitate that. And again, I just want to say now one more time, this is really not about McGill or let alone me. This is really about just providing a platform where we can help or work together to find out what this new technology can offer and how we can best support each other to show this to the rest of the world. Okay, so unless there are any final comments, I want to thank you cordially. So this is recorded, and we'll send out to everybody the link to the recorded. So in case you want to just go back and check for something that we spoke about. And then I will be in touch with you primarily initially by email to set up a kind of a communication platform where we can exchange on a confidential but internally transparent level on where we are. Okay, so thank you very much, everybody, for joining. It was a pleasure, and I'm so excited about this and how this is going. And I'm happy that others share this interest and passion. And I can tell you that this meeting will, when we look back in a few years, and it has to me even a much stronger dynamic than the Lake Louise team that we put together many years ago. And now we have the Lake Louise criteria; they are used everywhere. And I think this is eventually much bigger here. And so I'm very happy to have such a wonderful connection with so many great people. Okay, so thanks everybody. Enjoy the day and the weekend, and have a peaceful and joyful holiday season. And I hope to see many, if not hopefully all of you at the SCMR. And in the meantime, we'll continue the discussion.
Great. Thank you, everybody.
Okay.
Thanks, Matthias. Thank you.
Thank you.
Thank you.
Thank you, everybody.